So I'm handing off to my co-conspirator on all this, Mr. Samuel Kaplan. Carter, Jesus Christ. Arthur Kaplan's later. Samuel Carter's back here, and he is almost as morbid as I am, so here he is.
Thank you, Ren. As she said, I'm Sam Carter. I work at the Institute for Public Knowledge, which is a social science research center based here at NYU. And I want to take this moment, because I might not have it later, to thank Stephanie, Jack, Sonia, and Jessica for helping out with this, and especially to thank Ren. Ren, you've been an amazing colleague, a collaborator, a friend, and at one point a teacher, though I don't even know if you remember that at this point. And I really want to thank you for putting this together and for working with me these last several years. But I had the privilege of being asked by Ren to partner with the Institute for the Humanities to help put together a panel on some of the bigger picture society level stuff and some of the intergenerational stuff too, which I hope we'll get to. So it's another instance of the baby boomer generation sloughing off responsibilities onto the younger group. So, but I do want to set this up with some statistics that might help us think together about this big issue of end-of-life care in transforming demographics in the country and what we have to look forward to, because I think a lot of the issues we're talking about might be compounded over time. But the overall picture, familiar to many of you, is that more of us are living longer and will continue to live longer than ever before. And I want to make something clear here. More of us are living longer, from what I understand at least, and today at least, because of early life care and preventative medicine, not because of extreme interventions at the end of life. That this is sort of creating a new arc. But still, the fact is that more of us are living longer and will continue to live longer than ever before. And some numbers, and these are based on the US Census. Today, about 42 million Americans are 65 or older, of a population of 320 million. And looking out into 2040, we're looking at 80 million out of a population of 380 million. And looking out into 2060, we're projecting 92 million folks over the age of 65. That's 1/3 of our current population, out of a population of 420 million projected out. So those are numbers, and that's abstract. But I want to illustrate this with a personal example. I am 30. I am having a baby in a few months. It's my first child. You can applaud. It's great. So let's call this year that we're in right now year 0 in honor of my child's life or age. So this is year 0. So now today in year 0, the percentage population of the U.S. over the age of 65 is 13%. Right? So by the time we reach year 28, which is to say when my unborn child is 28, and I will be 58 years old, the total number of folks in our country over 65 will have doubled to 80 million. And by year 48, when my unborn child is 48, and I will be 78 years old, the population over the age of 65 will have reached 92 million, or 22% of the total population. That's up from 13%. That's up from 13%. So why is this important? I think what's important about this sort of trajectory is not necessarily those numbers, but what those numbers point to. And the number those numbers point to is the one number that I didn't talk about, which is that number 65. That number 65 is that sort of that age that we tend to talk about. Maybe it's 63, 62, 66, 67. But 65 is the number we as a country frequently use to talk about older people. And this number is not arbitrary. We collectively have chosen to use it, and lots of interests, and for lots of reasons, they try to nudge it up or down for all kinds of lots of reasons. But we have decided more or less that this is about when most, or at least many folks, are done contributing in some professional capacity to society, and thus should take time off to relax, or do whatever it is that you're supposed to do when you're done working, or for some folks in the country, for some folks in this category in this room, I'm sure that means continuing to work to support yourself because other things don't support you enough. But I want to use this sort of introduction just to plant a seed of an idea that I hope we can get to throughout the rest of the day, which is that these numbers suggest to me, more than anything else, that there's a gap in the ability of our social institutions to keep up with our medical institutions. That we as a society have gotten really good at extending life, but we're maybe not so good at matching our social institutions to reflect the extended lives that we have. So with that germ of an idea, which may or may not have anything to do with what they're going to talk about, but I don't care, I want to put it out there. With that germ of an idea, I want to turn it over to our two guests. Sharon Kaufman, who will speak first, is visiting us from the Department of Anthropology, History, and Social Medicine at UCSF. And Martha Holstein will go second. She's visiting us from the Health and Medicine Policy Research Group and Loyola University and the Center for Impact Research in Chicago. Thank you both for being here.
Well, it's a pleasure to be here, and I want to thank the conveners for inviting me, and I also want to thank all of the speakers who've come before us this morning, especially Heather and Nancy, for your comments about your own situation. Before I respond to Sam's population statistics, I do want to respond just to a couple of points of what we've been talking about before, and I want to say that the gentleman who said, I don't want to get to the point where I have a stroke and then not know what to do. I want to be in control of what happens to me 10 minutes before. That was a very articulate way of framing what, as an anthropologist, I can now put in other language and say what I think is the quandary of our time, which is knowing when, where, and how to approach the line of what any of us consider too much treatment. And I'm going to talk in a minute about why we're at this line today. But we are all at this line. And I think Nancy and Heather's personal testimonies are showing that when we get there, we don't know that we're there. We only know that we're there maybe a month after we've crossed it. Doctors are notoriously not good at showing us where the line is, and they are supposedly our guides through the system. So it's very hard to be able to answer your question. You can't answer your question. Nobody in American society today has been able to. We're at this unprecedented place of having this be the major question, and none of us knowing how to deal with it. But I also want to say, in looking at how we're mired down in the hospital and the problems that Heather and Nancy are facing, Nancy first of all in the community with the dementia parent, but then also what happens when one gets into the hospital setting, is I've been doing research in the hospitals on the end of life for a long time, and one of the pieces of language we use in anthropology to describe what goes on is it can be called the world is divided into two kinds of people, not three, the natives and the strangers. So that as an anthropologist, when I entered the hospital world, which is really a small society and which is really foreign and which is really odd, and it's as though one comes from another planet, the natives in the system are the people who work there, the people who go there every single day. They know what the routines are. They know the secret languages. They know the rituals. They know what needs to be done to get around. They're there every single day. It's a job 9 to 5 or 7 to midnight or whatever it is. And because they're natives, that is the reason that doctors don't want all of this stuff happening to them at the end of life. It's why they're so clear. It's because they're the natives. They see what has gone on with Heather's parents every single day of their careers. The problem is, Heather and me, when I entered as the anthropologist, we're the strangers. We're coming into a society, to a culture we know nothing about, even though it's in our own society. We speak English, but we don't speak the language of CPR, the rituals of ventilation, what happens when the vasopressor medications aren't doing what they should, and should we up the vasopressors? We don't understand this language. We have to learn it to the best of our ability. But the problem is we have to learn it under a condition of great stress. Somebody we love or think we should love, depending on family relationships, is in great distress. The other thing that happens in the hospital world is that doctors don't talk about death. And they're very bad at prognosticating, and a lot has been written about that, but they won't talk about it with patients or families. And a lot of the time, as both Ken and Joe have said, they want to talk about it if somebody gives them the entree, or if they have the courage to bring it up. But a lot of the time, they don't bring it up. I want to say one more thing before I turn to my own notes. about the advance directive. When I was doing my research on how death occurs in the American hospital, spending a lot of time as a stranger coming into native category, one of the things I learned about the advance directive, whatever it is, the living will, the durable power of attorney, now the pollster, the molster, whatever this document is, which we shouldn't have to have, is that about 10%, somebody said about 20% of people have them. Well, at the time I did my research a number of years ago, 10% of the population has them. I mean, who thinks about this stuff? Very few people want to, as both Ren and Sean mentioned. So about 10% of the population generally has one. About 10% of those find their way into the medical chart. And about 10% of those are followed. What happens to the 10% of those that end up in the medical chart? First of all, patients go against their own advance directive. Because you've got to remember, the advance directive is written, as with Jed's father, at home, over a glass of wine, in your kitchen table, when you're not in extremis. When you're in the hospital short of breath and you're 90 and your 60-year-old daughter says, "Mom, do you want to breathe?" The answer is yes, I want to breathe, thereby starting the whole process with the ventilator, et cetera. So people go against their advance directives, not realizing that they're going against their advance directives. But the thing is, when you can't breathe and want to breathe, that's what you want. It is no longer hypothetical. That's the problem with the advance directive. It's hypothetical. You're doing this at home when you're not in a critical condition. So people go against their own directives. And the other thing is, families go against the patient's advance directives because the family says, well, doc, do you think you could give him a chance? Even though my father said he didn't want A, B, and C, and the doctor says, well, of course. Remember what Diane Meyer said this morning, hospitals live under this litigation umbrella, and they're worried about lawsuits. And if a family member is asking, please do something, even though my father said don't do anything, the doctor will say, well, we can do A, B, and C. We can try a different course of antibiotics. We can up the fluids. The family member frequently says, yes, do it, thereby overriding the advance directive. So that's just something about the very end of life. But actually, I want to turn to farther upstream and to talk about this big quandary, the quandary of the line. So how did we get here? What's happened? So the first thing that's happened is that from about the middle of the 20th century, healthcare delivery started turning with its high-tech equipment into the hospital, okay? So patients were sent to the hospital more and more, and people stopped dying at home, and when they required diagnostic treatment and treatment for any kind of disease, they were sent to the hospital. So a great deal of medical care started to move into the hospital, really in the 1950s, but in the 60s and 70s in a huge rush. By the mid-1970s, the intensive care unit began. You know, when we go into a hospital today and we see all this stuff, we don't think that it all had a history. It all wasn't there forever. It's all actually fairly recent. So the intensive care unit didn't become a normal part of the American hospital everywhere in the country till the mid-1970s. And what's the first thing that happened after the intensive care unit came into the hospital and the ventilator came into the intensive care unit? The very first thing, the case of Karen Quinlan. People know about the case of Karen Quinlan, the young women who became unconscious, and nobody knows exactly why, but probably an overdose of drugs and alcohol. She wouldn't come out of a coma. They put her on a ventilator, and that started the public conversation about what do we do and who has control. Her case came into the public media and the public eye and the public legal profession 1 year after the intensive care unit came on the scene. So the intensive care unit, no question about it, it saves lives. Absolutely no question about it. We want it. On the other hand, it has a dark side. It's this dark side of the ability to prolong these states that we don't want, this ability to cross the line. So that's the first thing that happened. The second thing that happened, and after 1970-75, is that more people were sent to the hospital for acute care, chronic care, and it's where Americans ended up dying. So that now, and as of 20 years ago, most of us will die in a hospital. I mean, this is just the way it has been, unless, you know, we start a revolution and stop that, as Diane Meyer said, unless we start a grassroots kind of revolt. But we go into the hospital because we believe in medicine, because somebody calls 911, because the system is set up so that we go to the place where all of the acute care equipment is, and we get it. The hospital moves things along. Everybody gets the high-tech, life-saving care that was meant to be delivered and that we want. But there started to be, by the 1980s, there started to be a culture of complaint about this. And by the mid-1990s, this culture of complaint was really widespread, and we're now seeing the effects of this today, still in 2013. There's too much technology, too much of it at the end of life, too much that people don't want. In 1995, in response to this culture of complaint, the Robert Wood Johnson Foundation spent $25 million doing a study, which the results came out in 1995. I think the study started in 1990. And what they did was go into 5 academic medical centers around the country. The West Coast one was UCLA, and there were a couple in the Northeast, one in the South, and one in the Midwest. And they wanted to find out, it was the first time, as far as I know, somebody can contradict me, that a major study about the end of life was done in the hospital since William Osler did a study in 1908. So it was time in the 1990s to do this study. So they went in, and there were about 4,000 patients enrolled, and the goal of this study followed a bioethics model. It was planned to think, if we can only intervene, I mean, patients are rational decision makers, and if they can express their wishes as rational decision makers, the doctors can find out what those wishes are, and patients will get what they want, and people won't end up dying in the ICU, especially after 1 or 2 or 3 weeks of critical care from which they don't recover, and then they die. So they did the first round of the study for 2 years, and what did they find out? That doctors don't really, a great percentage of doctors don't know what patients want, that many are dying in the ICU after weeks of care. The families retrospectively are saying the patients died in pain. Anyway, the result was very disheartening. It was what everybody knew anyway. It was what was starting to appear in blogs, magazines, op-ed pieces around the countries, nursing journals, bioethics journals, all over the place. So the Robert Wood Johnson folks decided in their wisdom to do an intervention. And is Elizabeth still here from the morning? I don't know, our nurse and our doctor have left for the day. But the intervention was really fantastic in a way. It was to use nurses, the ones who talk to patients and the ones who know what's going on, to be the intervention. So the nurses, they decided, would run this interference. If doctors don't know what patients want and patients aren't able to find the doctors because they're too busy to express what they want, the nurses will intervene. The nurses will ask the patients what they want, then we'll go find the doctors and say, Dr. A, this is what patient B wants. And back the other way, and then it would say to the doctors, what would you like to do? And then the doctors would tell the nurse, and then the nurse would go tell the patient, and is this what you want? So they were brought in for the second part of the study to serve as intermediaries, with the hope that, oh, this way everybody will understand what everybody wants, as though one could know what one wants, okay? As though one could know what one wants. And we've learned from Heather, you can't possibly know what to want. As though one could know what to want in this kind of a situation, and that everything would then be resolved. Well, guess what the results of the study were? No change whatsoever. The same number of people died in the intensive care unit in the same amount of pain after the same number of weeks of being on a ventilator. At which point there was, I love the word tsunami, from Ken over there. There was a tsunami of reports and follow-up studies, and here we are today with this matter not entirely resolved still, but with the conversation, I'm glad to say, more out in the public domain. So this has been a little bit of the history. What's gone on since that support study, with the first piece of which came out in 1995, is that a number of other developments have come together, creating what I'm calling a perfect storm for today's predicament, this predicament of where to draw the line. And I want to mention 5 of them. And I've come to understand what these 5 are because for the last 7 or 8 years, I've been looking upstream from the end of life. I have been doing research on the kinds of high-tech treatments that are prolonging lives. So to modify a little bit about what you're saying. So in other words, it isn't just antibiotics and vaccines in youth and good sanitation that enable us to live longer. It's also the fact that in an aging population, who's getting medical care? Older and older people. And because of that, medicine has been able to do more and more for an ever-aging population. And I have been looking at the domains of kidney transplant, liver transplant, the cardiac defibrillator, the little thing in the chest that works like a crash cart, the left ventricular assist device, which nobody maybe has heard of yet, but you will. It's an artificial heart pump. Chemotherapy for advanced cancers for patients over the age of 80 and 85, and renal dialysis for people over the age of 70. So I've been looking at these life-extending technologies for people over the age of 70. And what I realized is they are there because of a system that has these 5 elements. The first one is, and all of these things have come into being really in the last 15 years, and in a way, they're hidden in plain sight. They aren't secrets, but in general, the public hasn't been able to be truly outraged because the public doesn't know about them so well. So the first one is that somewhere in the middle of the 1990s, more biomedical research started to be funded by private industry, that's the pharmaceutical industry, the device industry, and biotech, than by the National Institutes of Health. Now, you don't know this in your daily lives, and patients who go into the doctors, we don't know this. This doesn't affect us so specifically, we don't think, but it really does, because when you have for-profit private industry funding research, what they're doing is organizing the direction of the research question more than ever before, and deciding how to interpret the research results. And the effects of their interpretations of research results influences what doctors recommend and what patients get. So this is complicated, as is everything we've discussed this morning, because most research is actually funded together, the NIH and industry. But there has been a tipping balance, and it's more by industry today than NIH, which means the profit motive starts to play a bigger role way upstream from patient care, but in the biomedical research engine and in the way in which evidence from clinical trials is produced and then interpreted. So that's the first thing that has happened in the last 15 years. So that, for example, when you have the device industry doing research, a series of studies between 2002 and 2005 showing that the implantable defibrillator can be used for patients who haven't yet had a heart attack, but that it will prevent heart attacks and that it will save lives. It will prevent the risk of death. And you have all these studies coming out with good evidence showing this. What happens is that Medicare then reimburses for the device, and most of the people getting it, of course, are over 65. If Medicare is paying for it, patients and their families aren't so worried about it. As Heather, I think, but Nancy and Heather both explained, Medicare is going to pay for this. That you weren't going to have to pay for these high-tech treatments out of pocket. Medicare is going to pay for it. So studies have been done, mostly funded by the device industry, to show that there are greater populations. They want to increase market share. And if the market for the device is only people who've already had heart attacks, that's a smaller market than those who will potentially have a heart attack, which is anybody. So that they have increased the population for who are eligible by Medicare criteria and clinical trial criteria for the device, so that by the time you get your the patient or the patient's family or the doctor in the clinic, all of this stuff has happened way before. So when the doctor says, you know, according to clinical trial outcomes, you're eligible for a defibrillator. Now there's the pros and the cons and the this and the that, but you're eligible for one. I heard this language a lot in my research, a lot. The word eligible is used a lot. Patients think they've won the lottery. Families don't want to deny their elderly relative potentially life-saving care. So that the decision which is put onto the family or the patient is something that is actually offloaded from the medical profession today. In other words, these options are huge ethical decisions put in the laps of patients and families. But when you're eligible according to Medicare criteria and clinical trial results, you say yes. It's very, very hard to say no. It's hard to say no all along the line. But I'm trying to give you a picture of one of the reasons that's leading up to this perfect storm that makes it so hard. So we don't want to say no to any of these things, and the defibrillator is a great example of this. And of course, the thing about the defibrillator is, we heard in the Radio Lab show, and the other panelists, people want to die in their sleep. You know, this is how we all want to die. When you're asked, you know, people want to die in their sleep. The thing about the defibrillator is it prevents sudden death. It prevents the kind of death we want. So yes, it can put a potentially lethal rhythm back into a normal rhythm, cardiac rhythm. That's what it does. Now, the device was created for younger people, but now its use is being pushed up. The age of patients is going up and up for those who get the device. And it makes us have to think, and we're not thinking about that so much. So, okay, I'm going over my time, but so I want to say there's more technology, and more technology is used on ever older patients. And the thing is, because much of it is very successful, in other words, it is prolonging life. Everybody knows somebody who's had valve replacement, who've had cardiac bypasses over the age of 80 and 85, and who's done well. So there's great pressure on all of us to say yes, because these things work. It isn't as though it's only negative. I mean, mostly it's positive. And so this is one of the reasons why we hesitate, even if we see the line, about crossing it. Another piece that's contributing to this perfect storm is, because of all these technologies and because they're so good, the public has an expectation that we want to grow old without aging. And that's a term I want to give credit to my wonderful sociological colleague, Stephen Katz in Toronto at the University of Trent. He came up with that today what's going on is we all want to grow old without aging. And it doesn't just apply to Botox and bungee jumping over the age of 85 or whatever, but it applies to, we want medical technologies that will enable us to get back to the way we were. Doctor, I want to get back to the way I was. I hear that a lot in clinics with people over the age of 85 and 90. What can you do? And thereby we come up to this line. The other thing, of course, is who's paying for this? Well, Medicare's paying for this. And of course, we're in a health reform crisis, we're in a Medicare crisis. And I think one of the things that isn't seen so much by the public in all of the healthcare reform debate, the Medicare debate, is that the biomedical research engine that is churning out more clinical trials than ever before. And since the year 2000, this industry has mushroomed. It has just grown exponentially. And one of the big reasons is because it's driven by industry so much. So there's more clinical trials, which means more evidence to be evaluated by Medicare. The private insurance industry generally follows Medicare's lead in what to reimburse. Well, here's the double-edged sword again. Of course, we want Medicare to keep up with the research. You want Medicare to know what are the latest therapies because you want it to reimburse when you become 65 or for your 90-year-old parent. You want Medicare to be paying for this. I mean, this is the only social insurance we have in this country. We want Medicare to stay up to date. But the problem is, there's so much more evidence now, and so much of it is created by private industry to increase market share, that there's a huge crisis in the cost of Medicare. And as individual patients and families making personal ethical decisions about crossing that line, we don't think about Medicare. We think about the best possible thing for ourselves or our family members. So I have a lot of other things to say, but I'll stop there for now.
Okay. Well, I turn my microphone on. Okay. Well, this is always a pleasure. Sharon and I have known each other for many years, although we haven't seen each other in many years. So this is a great treat, because for somebody who does kind of ethics as I do, and teach in a philosophy department, although I'm not a philosopher, I keep telling my philosopher colleagues that they really have to read Sharon's work, and they really have to read the work of anthropologists, because philosophers are so wonderful at telling us how we ought to do things, and then without grounding it in how it actually works in the community. So I think you probably see the reasons why. In fact, the chapter I last wrote on dying, I call it Beyond Rational Control, because I think we put such a premium on rationality that, I couldn't be here this morning because I'm actually here on a family visit, and so I went to an 8-year-old soccer game this morning, which was my first priority, I confess. So I did miss the morning. But I want to make a comment, and that's sort of based on what Sam was saying, and that's the freedom we have to say we. And I have two very brief points I want to make about that, very brief. We are living longer. Well, no. Some of us are living longer. And the some of us who are living longer are probably people in the audience. And I don't know if in all the debates around raising the age of Social Security and everything else, you hear, well, people are living longer, people can work longer, it tends to be a series of irrationalities, because how can people work longer when there are no jobs, and you're over 55 and you lose your job, you never get another one. But the we, and I quote Paul Krugman here, and probably not exactly the way he says it, but he said, why should the 65-year-old janitor work longer because the banker is living longer? There's a vast discrepancy in age of death depending on your income. And there's an article that was in the New York Times some time ago that if we really want to improve health in this country, we really have to eliminate poverty or do something about poverty. So we are not living longer. Some of us are living longer. And I think it's really important to kind of disaggregate and begin to break up this we. And the other place that, and I think the rational control and all the talk about advanced care planning and advanced directives, and Sharon's statistics were even lower than I thought they were, so the number of people have them, how they get followed, and how they get used. But again, it's about us. We're comfortable, some of us, talking about it to our family members over a glass of wine, as I've discussed it with my daughter, and I was delighted to say, oh yeah, Mom, of course, if you want to go, you want to go. But she, we were sitting over a glass of wine. I wasn't really, kind of lying on a bed, and she's trying to decide what to do. But I was once giving a talk in Indianapolis, since I live in Chicago, to a group of maintenance men. And they were maintenance men in senior housing, affordable housing. So they were around old people all the time. And I use the word old people very freely. I'm an old person, happy to acknowledge it. Learned that from Maggie Kuhn, founder of the Grey Panthers. I'm an old lady and damn proud of it. And we should say that more often. But anyway, somebody brought up the subject of end-of-life care. This was an ethics talk I was giving. And the place fell apart. They were really angry. They did not want to talk about it. When I raised the issue of advanced directives, no, I don't want to talk about it. That's in God's hands. It's nothing to do with me. And so again, let us be really careful. It's about us. It's about people like us. That doesn't mean others don't have directives and talk about, but we don't speak for the whole world of people who clearly, dying is, at the moment at least, a universal happening, although some would like to make it optional, but at the moment it's not. So I think we have to be really careful that who it is we're talking about, and that we don't represent everybody. I'm speaking about people sitting here and people like us. So what I want to do a little bit more specifically is even go back further into the background that then Sharon has, and talk a little bit about why do we seem to find all kinds of reasons to try to postpone death, even though we say we don't want it, for all the reasons you gave, which are very hands-on, right there in the minute. I want to push it back and actually take up the theme that Sharon mentioned from Stephen Katz, which is, it's age without aging. And so the few things that I want to talk about today, and let me assure you in advance, because you may not believe this after you get done with me, I'm really not a curmudgeon. I'm really a rather nice person, but
She is.
But I'll take evidence after I'm done. You may not say so anymore. But because what the growing cultural norm in our society right now is we really can age without aging. That somehow, you hear it, 60 is the new 40. Well, I'm here to tell you, I'm 72. I'm not 40 anymore. I'm not even 50 anymore. I'm in pretty good shape, however you define shape. But the point is, this is the new language of America again, and it's about us. It's not universally. So what I've called this, and when Sharon and I were talking about our little panel here, I call it the eternal postponement. We can talk about postponing death indefinitely for a variety of reasons, and I'm a New Yorker, so I have to talk with my hands. But the problem is, we want to postpone aging as well. We want to push everything into some kind of unknown future. And part of the reason we're insisting that we can do this is we're learning all these things we can do. And if we live right, and we eat right, and we exercise right, and we keep on being engaged, we really can postpone age for a very long time. It's our eternal postponement. So we postponing death, even though we may not want to and say we don't want to, fits into this larger picture that let's just shrink the period of aging to maybe dying in our sleep or something of that sort, or at least, the old one-horse shay argument, you kind of go along, and then you die. That you don't kind of this way, or you don't go this way, you just collapse, which, well, most of us are not going to go that way, especially if we have implanted defibrillators. We'll just be hovering around forever. So I want to suggest that postponement of death is part of this much larger cultural trend. And the trend consists of many threads all coming together around the notion that age is irrelevant. And a lot of this started, I'd say, in the 1970s with, but I'll talk a little bit more about that later. So that age is irrelevant, the 60 is the new 40, that we can do and live in an endless middle age, and the infirmities that we have, all seem to be postponable if only we had behaved right. And I've been going around reciting, I've been visiting my daughter and family. The Nutrition Action Center has now told me, and I believe science in the public interest, I believe in them, the 10 foods that I have to eat, they're power foods. So I'm going to keep on eating these foods and we'll see what happens. But we're all, and that includes in case you want to know, sweet potatoes, mango, so.
Kale.
But in any case, kale. You want all 10 of them? I don't have time for all 10 right now. But a lot of them are orange. Sorry about this. It's been an interesting day. So anyway, so most things seem to be postponable, except perhaps for Alzheimer's disease. But now I read more and more ads about brain activities and that we can do these brain exercises. And I do the crossword puzzle, but it's not one more thing I have to worry about. Now I have to exercise my brain. It's not enough to exercise my body, but I have to exercise my brain because So there's more and more things that are postponable. And so at that time of life, whether we call it, Bernice Newgarten years ago called it the young old, well, now the new name is the third age. We have this time that's after retirement, but before we're so decrepit that the most important goal for us is to keep out of a nursing home. No other goal at that point, but just let's keep us out of a nursing home. And so then of course, by keeping us out of the nursing home, raises a topic that is very important, but I'm not going to deal with it, we'll stay out of the nursing home no matter what kind of burdens it places on our family members because we don't have a public program to take care of us, but that's an entirely different topic. So one of the things that I think we have to think of, and this becomes sort of an institutional, structural framework, and we really hear it institutionally with this idea that we can postpone the age of retirement for Social Security, which again is another big topic that I am not going to talk about. But this eternal postponement that I've been talking about is an effort to change the framework in which we age, but also an effort to change the institutional framework, which is around Social Security, around Medicare. Can we delay the age of Medicare? It's, by beginning to think that we can postpone age forever, age without aging, we can, no problem. We can delay Medicare to 67. We can, delay Social Security until you're 69 or 70, because after all, we're all so much younger these days, even though we maybe dress differently, but we're so much younger. So the contemporary goal is to change all the evaluative standards by how we judge old age. And when we get old, like any other point in our lives, we want to live it well. We want to live it so that we're respected, that we're not marginalized. And so there's been a big effort to try to make that happen, and that's what I really want to talk about. So let me give a little bit of background here. The intent, I think, is noble. I mean, I think the intent is really good. I've debated these topics for probably 25 years, and I know my debate partners are very well intentioned. I think they're wrong, but I think they're very well intentioned. And so first of all, historically, very shorthand, the image of old age was, decline. The whole notion that decline and loss, as you get older, you lose this and you lose that, you get white hair, you lose all these kinds of things. And then we began to have resistance to this. We've got to reverse this decline and loss framework, which was really very good while it lasted because, as the late Bob Binstock pointed out, it led to compassionate ageism. We're going to do all kinds of things for old people because, after all, we're declining, we're frail, we need all the help we can get. And that led to a bunch of very good and very significant public programs. But then there was the beginning of this resistance, and this is sort of before I started studying it intently, but I remember going to aging meetings, and you may remember this as well, Sharon, but I used to see these people running around with, we used to have carousels. That was before PowerPoint. I had these big carousels. Come to my lecture later. I'm going to talk about sex and old age. So suddenly it was like the big no pun intended here. But this was going to be the big hot topic was going to be sex and old age. This is in the 1970s. And what, of course, they completely forgot about in the grand notion of we is that most women tend to be widowed and don't have regular partners, but it's kind of irrelevant. We'll forget about that. Then Bernice Newgarden, a great sociologist at the University of Chicago, Northwestern, introduced the idea of the ageless, that age is irrelevant. We're going to live in a society in which age is completely irrelevant, and she gave us the ideas of the young old, the middle old, and the old, and everybody, if you're the young old, we're just like we're a middle-aged person. And the one thing that has happened, and that I think is accurate, is that there have been big changes in age-based rules. I mean, you can be a grandmother at 40, and you can finish your doctorate at 60, and you can have your first child at 30, or you can have your first child at 40. Well, with IVF, 44, 45, you can have your first child then. So we've changed a lot of those rules. I mean, we dress differently, but again, the we is us. It's not we across the board. So yes, indeed, that part of it is true. We go back to school, we can learn new skills. So in that way, age has become much more irrelevant than it used to be. But then this notion that somehow we can age without aging had a darker side. And this darker side emerged in the 1980s. And it wasn't about old age being about decline and loss. It's about old age being about being a greedy geezer, about being very wealthy. And there was an organization that formed called Americans for Generational Equity, who had a major conference, I think it was 1984, and based on an article that was in Demography magazine by Sam Preston, saying old people are no longer the poorest. It's now kids, which is true, but kids are sort of like not poor on their own. They're poor because we don't take very good care of their mothers, but somehow kids are not looking for an apartment or going to the grocery to buy food. But in any case, this idea that old people are ripping off everybody else, by virtue of Social Security, Medicare, that somehow we were very greedy. And by the way, do you know who introduced the term greedy geezer? Alan Simpson, the person who's the co-chair of the Simpson-Bowles Commission, who told us about the way we should change Social Security. And so Simpson introduced the term greedy geezer. It was a cover story on the New York Times. And all of this was also, well, if we can stay young forever and age becomes irrelevant, and after all, we're no longer the poorest in America, which is absolutely true. Why are we not the poorest in America? We have a great public program called Social Security, which is not nearly enough to retire with. That's, again, another topic. But we have it. If only we would give it to people of all ages, perhaps everybody could be equalized in some way. So anyway, so that was the downside. We can age without aging, and we can, age can become irrelevant. And oh, by the way, you're all 3 minutes? I better talk faster than I better talk 5 minutes. Well, I am a New Yorker, so I can talk really fast.
We'll postpone it.
We'll postpone it. Eternal postponement, but I have to get home for dinner tonight. So it's my granddaughter's birthday. So the other things that happened was something called, the big push in the later 1980s was something called productive aging. And that had two functions. One, it was to prove that we old folks were not a drain on society, that we weren't the social problem that we were made out to be. Look at all we contributed. And the data was collected, how many hours of volunteer work we did, how many people were still working, to some extent how much caregiving that we did. And it was this sort of notion that we're worthy and we're worth paying attention to, and we're worth respecting and not marginalizing as long as we're productive. Because we are just like a middle-aged person. We value money, we value activity, and so on. And all of this began to fill in this little hole. In 1991, Peter Laslett, who's a British historian, introduced the term the third age. And this was to be this space between retirement and the time when we became, so old and frail that all that was left for us was to go into the nursing home. And so this third age was kind of a void. We had to fill it. Well, what does it mean to be in the third age? Well, the one thing that there was an assumption is that the third age was somehow an empty space that can just be filled up with all kinds of things. And Kathy Woodward from Humanities Center in the University of Washington pointed out in 1991, no, it's not an empty space. There's all kinds of things that are happening to us. They may not be things we want. They may be physical. They may be mental if we don't do our brain exercises. It's not an empty space, that we have to acknowledge that there are things happening. So there are different ways that we design to fill this space, and I'll try to round it up with this space. So the first thing that I mentioned, productive aging, was one of them. Then we began introducing this whole concept of, quote, very broad, positive aging. And that's where I've gotten into the most trouble. How could anybody be against positive aging, except me? How could anybody be against positive aging? And it becomes this very broad term. Then successful aging. Sharon talked about the big study that funded support, the big intervention. Well, successful aging was at $80 million or a huge amount of money the MacArthur Foundation funded to look at ways that we can age successfully. Well, who wants to fail at aging? So the way you do that is you stay healthy and you have the immune system of a 30-year-old and you exercise regularly and you're engaged, and it's highly individualistic. It's about you. It's about you getting out there and doing all these things to staying well. What they forgot about, and although it has been pointed out now quite a bit, is that, again, we, my kind of deconstructing the concept of we can do all these things if we live in a safe neighborhood, if we can buy kale
Orange
and
foods.
broccoli and orange food, we could do all this. But it's not as if like we could do this on our own. We could do this if we don't have any money. We could do this if you live in neighborhoods in Chicago. We're so proud to have the highest homicide rate in the country. Well, you're not going to go take an evening stroll as if you lived in a safer neighborhood. But everything was highly individualized. We can do it on our own. And the problem that happened with this is that there began to be sort of a moral judgment. Somehow, if you didn't do this, if you were 70 or 65 and you had diabetes and you had osteoporosis and you had blah blah blah, all these you were morally judged. You didn't live right. I mean, you could have lived right, but you chose not to live right. You had that piece of chocolate cake, and therefore, I'm teasing, but it became a moral judgment on people without trying to look at the social conditions that made it possible for some people to do certain things and not others. It makes a big difference if you have, a gym that you can go to, or you've worked in construction and you come home and you just want to collapse. But then the one that was the most fun, actually, to fill this third age period, was postmodern aging. Now, these people had a really good time. This was really good because you could totally reinvent yourself. You could go off to exotic places. You can dye your hair red. You can become a belly dancer. I wanted to do purple, but my hairdresser said it wouldn't work. It would have polka dots because it's so short. But you can reinvent. You can do whatever you want. What a liberating thing. So you had the one side that said you have to keep on being productive and busy and everything else, and on the other side that you could just go have a good time, go off and just have this wonderful time. And then the next step in all of this was something called civic engagement. Now, who could be against civic engagement? Not because I think it's bad. I'm a pretty engaged person, but engaged with activities. But it easily became, instead of being a civic engagement, because it is pretty good for us to be engaged. Rather to hide out. But it became not. It would be, look, let's create opportunities, let's welcome older people into this role. No, it became, if you can do it, you should do it. It became a new normative standard. So it went from, let's create it, let's welcome people into it, to saying you should do it. And that's the source of my objection, that it went from an opportunity to a new normative standard. So these are some of the things, and the stress was on individual responsibility. All the funding, lots of foundation funding for this, but none of it went toward political advocacy to begin to change the underlying conditions that would allow people to do more of these things. Let's cut all of those things. And I think the darkest side of all of this, the embrace of this sort of positive images of aging, has been undermining and undercutting the kind of social support, the kind of social programs that allowed us to grow old decently and allowed at least generations up until now to grow old. Because after all, if it's all up to us, and if we would eat well and exercise regularly and do brain health and be civically engaged and be productive, then we don't need all this public support, all this public help. Well, so it began to throw a wedge and to begin to undercut all of this. So this sort of what I call this, this Peter Pan syndrome, not that I won't grow up, but I won't grow old, I think feeds into all the efforts of all the anti-aging efforts and all the efforts about doing one more set of treatment, one more thing. It all fits because we have learned all along is that we can keep on postponing all of that. And I'll end by just saying, again, deconstructing the we. Many of these things are class and gender-based. They're not for everybody. They're for certain people. They're not for the woman who scrubbed, nursing home floors, at the end of the day. All she'd want to do is take on civic engagement. I think she wants to go home and put her feet up, So it's very gender and class-based. It's what's good for us is good for everybody. And also it reinforces this whole ethos of productivity, this whole ethos of activity, what Kevin Eckert some years ago called the busy ethic of retirement. Just keep busy. You hear a lot of people say in retirement, I'm busier than I've ever been in my life before. Why do you want to be busier than ever? I don't quite figure this one out. And the hedonistic vision, that you can go off to Tahiti on your canoe, is, it's really not for people who don't have any money, to take off for a year and go floating down some river in their canoe. And all these romantic images of people who are living such a great life, they're all tall and slim and tanned, and they're not. Now I'm going to go so far. They're not even most of us. There's somebody else. So anyway, the next step, which I don't have time for, but the next step would be to say, I want us to think more about freedom, but not freedom without responsibilities. So if we're going, I want to answer the question, what does it mean to age well? What does it mean to have a good old age? But I want us to think, I'm thinking about virtues. I'm thinking of ways that we do have obligations as we get older. But those obligations are not to keep productive, not to keep busy, not to keep involved, not to be successful. But that's a topic that I would love to hear from other people, because my own struggle now has been, I do believe I have obligations, I do believe I have responsibilities, but they're not to be engaged in a million activities and to feel, but it's to be a certain kind, go back to the Aristotelian virtues, and to go back to being a certain kind of a person. And my negative closing note, since I do have a reputation of kind of making everybody share my gloomy mood, is that I don't think we're going to eliminate ageism in our society. I don't think any of these efforts are going to eliminate ageism. I'm just trying to figure out a way that we can feel far more, less discriminated against, less judged by how we look, how old we are. Every time I walk into a classroom of 20-year-olds, I think about that. So I'd like anybody who has thoughts about what it means to age responsibly, without having to have all these ought tos, I would welcome a conversation about it. Thank you.
Thank you both. Thank you both. I promise we're going to have lots of time for audience questions, but I'm going to ask a couple, maybe opening questions. One first, going off this idea of eternal postponement, which you talked about in sort of cosmetic terms, or diet, or activities, brain exercises, or whatever that you could do. I wanted to invite Sharon to talk a little more about more extreme measures of eternal postponement, and in particular, some of the stuff we talked about on the phone and that Renan mentioned about extreme kinds of transplantations that you'd been working on, because I think that's a really interesting addition to this conversation.
Sure. So one of the treatments I've been looking at, because I have been interested in the issue of scarcity and scarce resources, and I became very aware, of course, that kidney transplant is, I think everybody knows, there's the United Network for Organ Sharing, the national pool for deceased donors. That pool has not been growing much. You probably see drives all the time, posters around, sign up to donate your kidneys, and there's been calls for how to get more people to do this, because it's a pretty stable and stagnant, the percentage of the population that has made the decision to donate after death. So what we have in an aging society is that pool has been staying pretty stable, whatever the number is of available deceased organs to go around to the regions of the US, yet the demand has been skyrocketing. One of the reasons the demand has been skyrocketing is that older people are now eligible for kidney transplants and liver transplants. I've used the word eligible in quotes because it's the Medicare and clinical trials term. So that the problem with the eligibility is, and the double side sort of all this is, this great clarity. Kidney transplant saves lives. There is no question about this. This is a great therapy. It saves lives. It prolongs life. For young people, of course, it gives them a life. But because now medical treatment is so good for older people, because there's been more and more research done on an ever increasingly older population about how to do The surgical procedures, now they can do it laparoscopically, not with a big incision, which means it's easier if you're older, less anesthesia time, all of this. There's much more that's understood about immunosuppressive drugs. It means that kidney transplants are successful more and more often for older people. So that the very first time I walked in to the nephrologist at UCSF and said, you know, I think I want to study what goes on in this clinic. I'm interested in kidney transplants for people over 65. He said, well, what would you do if your father needed a transplant? There isn't enough, there aren't enough organs in the pool. And it might be a 7 or 8 year or 10-year wait if he has type O blood in the San Francisco Bay Area region. In any major metropolitan area, there's a much longer wait than if you're in a rural area. So I sat down in shock. I had, of course, never thought about that. And my first thought was, well, what if one of my children needs one? How could I donate to him if one of my children needed one down the road? So his question, what are you going to do? Because there's a scarcity, because there's a shortage in the deceased donor pool, what are you going to do if your father needs one? Put me immediately into a 3-generation frame of thinking right away. We were connected. We were absolutely connected, and medicine connected us more than ever before. And it also brought me immediately into thinking about, well, what constitutes my obligation as a child and a parent? What is medicine doing to my sense of love and obligation? Because it is posing this question to me, because there is a shortage created because there's more older people who are successfully treated with transplants from the deceased donor pool. So I started doing research in my own institution and at various other places, and started doing interviews around the country. And what I learned very quickly is that in 2001, the numbers of people who were donating their organs as living people exceeded for the first time the deceased donor numbers for kidney transplant. So living donor transplant is something that's on the rise. And what I learned also very quickly is that everybody, because the transplant technology is so good now, because immunosuppressive drugs are so good now, and because you do not need to be a direct blood relative any longer for a transplant to be successful. In other words, all the advances in medicine have made everybody a potential donor and a potential recipient. If you live long enough, you may need a kidney, and if you live long enough, someone you know may need a kidney, and you may be obligated to think about offering, and they may think about being obligated to ask you. So I've done a lot of research on this, and I want to just read you one quote from a 76-year-old gentleman who received a kidney from his daughter. Now, one of the things that I have seen in the clinics over a period of a decade is that older people say, I'll never take a kidney from one of my kids, never. And the kid, age 30, 40, or 50, says, but Dad, but Mom, I want you to live, and you can live. And the doctor says to the patient, you have a supportive family member. And evidence now shows that living kidney donation is even better than deceased donor donation. Guess what? Because the kidney has a lot of perfusion, the blood goes through it, it's alive right away, it'll take right away, so that your chances of a successful transplant are even greater with a kidney from someone you know. And if you wait on the wait, you're 70 years old now, you have type O blood, because of the shortage, your wait time is 10 years. I can't guarantee that when you're age 80, you will be medically eligible for an organ, and besides which, evidence now shows that 10 years on dialysis, waiting for a kidney, your kidney function will get much worse and your life expectancy will go down. Great pressure on the adult children. But the patients, the older patients, still continue to say, I don't want, until here's something that was very typical. The children talked me into it, says a 75-year-old man. I said, I'm not taking my daughter's kidney, but other family members persuaded me. I kind of went along with my daughter's insistence, and we didn't say too much one way or another, whether I wanted to or not. But I was hopeful I could get a deceased donor right up to the night I was hospitalized. My point was, I didn't want to take an organ from my child. If it were the other way around, I would have gladly given my kidney to one of them. But because it was coming as a hand-me-up sort of thing, I thought about it a lot. I didn't feel like it was the right thing to do. Help should go the other way, from parent to child. There were times I just didn't want to do it. There was no real point where I decided I wanted to have it done. I just went along with the flow. I was going along for the ride because things were being arranged for me. Medicine processes people through the system, and it does it very well. And you know, his family's delighted. I mean, it was a successful surgery. He would have died otherwise, eventually, unless he went on dialysis, and it was successful. But I think this raises the point of this symposium, which we haven't really discussed that much, of the intergenerational commitments, obligations, and relations. And I think the kidney story, and now the living lobe of the liver transplant story, which is much small, it's happening with much greater, less frequency than kidneys, is just the starkest example of what happens as more and more people become Medicare eligible for life-prolonging treatments at greater ages. So I'll stop with that. Yeah.
Thank you. And one more, and this is an invitation to comment again for both of you. Martha, because you mentioned, in the postmodern aging, the idea of someone hopping on a raft and floating out to Tahiti, I have to bring up this ice flow, which we were bringing up earlier. And this sort of story that's common and out there that when someone gets old, put them on an ice floe, send them out. And I wanted to ask you, Martha, first actually. I mean, you mentioned, you got into it at the end, sort of what it means to be, in your mind, sort of an ideal aging person in your position, and ideal is maybe a bad word, but what are models that are sort of different than the productive aging or the positive aging or the successful aging? How can we talk about this better, and are there models in other societies where we can go there?
And that's, I am on a rem. I mean, that is a useful question. I have a feeling that models are not what we're looking for. In my very pessimistic way, that we're not going to fill in this so-called third age. We're not going to eliminate ageism. I think a lot of things that are going to happen is I'm deeply committed to giving people the underlying conditions under which they can live their lives decently. I'm an old-fashioned lefty, and I think we have to give people whatever they need to live. So I would start certainly there, which in our society today is about as likely as my having purple hair, but it's just not going to happen. But that would be my first wish, that we do find a way to do this. I think we're going to find some of our comfort where we don't feel, we're a mixed group of people of different ages, and you're 85 years old. I heard this from a very, very involved, active, at that point she was about 84. When I go to my church and I'm on the finance committee, I speak and nobody listens to me. A younger person says the same thing and they listen to him. So I just don't know how we're going to change that, which is what all these efforts are trying to do. It's to show we're just like everybody else and we're productive and we're active, all these things. So I think we're going to find a lot of it sort of in micro-communities among people who are comfortable and who are more like us, where the discrimination won't be that rampant. I mean, I wish there was a way that I could think, and I would certainly hope if anybody has ideas, you'd share it. So my own sense is that there are things we have to accept about ourselves. I've been told, well, we should never talk publicly about, oh, my back hurts, or, because it'll create ageist, ideas. Well, I think partly when I talk about virtue, probably we shouldn't complain. It probably is a virtuous thing to do not to complain a lot. or not to complain a lot about, oh, all these kids on their technology, you know, everybody's got their smartphones, and, you know, which I actually complain a lot because people use them in very impolite kinds of ways. You know, I think, so I think in the way, through our actions and how we behave, through the virtues which we have yet to develop and think about, and there's been, except for your own, well, the late Sally Ruddock from Greenwich Village, wrote on the virtues of age, a lovely, moving chapter. There's been very little work done on that, and I think it's important to do it. But I don't know how we can do it. Because it involves such a huge cultural shift, because we do value money, productivity, earning, Sharon's discussion of how even medical technology is now in the hands of the private sector. How are we going to learn to respect people and to not marginalize people who don't fit those norms? And the only way, you know, by introducing this productive aging or civic engagement, that becomes the way that we try to value people because they do meet these middle-aged norms. And my own notion is there's something different about being 70, even if you're in good health and, you know, could run around the soccer field with your kid, than there is, because we're closer to death. We've lived more years than we're going to live, and I think it makes every moment and every day far more important to think about how do we want to live it and how do we want to live it well. But how to do it in a larger societal way, I don't know, and I really would love to hear if anybody does have good ideas or thoughts, even thoughts about this. It would be very valuable, I think.
I can add to that, and here's my segue to the Eskimos. Yeah, just following up on what Martha's saying, I think, you know, one of the things we need to do at every life stage is to work on acceptance of the stages of life. And the woman who made the comment earlier about learning that Eskimos send their elders off onto icebergs, that isn't, yeah, that's close, not exactly it. The thing is, in small hunter-gatherer societies, of which there are very few anymore, if any, these were small face-to-face societies where there were 100 people in a group. They, of course, lived on the resources that they could walk or run to, so it was only within the area in which they lived. And they were very aware of the human lifespan and the human life cycle and the resources in their eco niche that would enable their numbers to survive. And so this course, I'm not sure exactly how the popular conception settled on the Eskimo. It may have appeared in the first anthropology textbook and then it stuck there. But most of the hunter-gatherer societies in the past knew, I mean, there was no life-prolonging medical technology, I mean, but they knew that when somebody could no longer contribute in one way or another, and it didn't mean a productive busyness, but it could have meant taking care of the younger generations, passing on the oral tradition, the stories, the myths, the legends, the folklores, the knowledge, the education, how you build a poison arrow, how you do all of this, how you make the clothing. When they could no longer do this and were infirm or blind, beginning to be blind, could no longer walk, could no longer go on the cycles, it was time to enable them to detach and let go. And every society's had their rituals for doing that. And actually among the Native Americans, it was isolating them. And for the gender issue was that when a male member of a Native American society died, the widow was put outside and usually froze to death in the winter, depending on where she was. There was no more place. But there was, you know, there was a social acceptance of how you deal with population amidst scarcity, how you deal with resources in your society. And that was the way it was done. And, you know, that is exceptionally foreign to us today, exceptionally foreign to us. But it enabled, one could think of it in terms of the issue of the social good. If that mouth isn't fed, we can feed the next generation. And I think, you know, maybe there's something to learn from that, if it's possible at all. But
and, you know, and I think if we start, in some ways, all of us thinking of our life as a narrative, as a story, then on a personal level, again, I blame the others for being individualistic. My individualistic choices are based on an sort of a structure in which we have the resources to live decently. I mean, the money, whatever it takes to live decently. But I find myself touched by something like Emerson's poem, Terminus, if you get a chance, and that there's the sea, but there's the shore, and that we have to pull in our sails. Or Barbara Meyerhoff's wonderful, book, Teach Us to Number Our Days. And I borrow, again, because I do think we have to struggle with this personally from, I won't give the whole tale, but from the Midrash, which Rabbi's talking, and one saying to the other, live every day as if it's your last, and the one other rabbi says, well, how do I know it's my last day? And that's why you have to live every day as if it's your last, because none of us know. And as we get older, as we think about how we want to bring our life to a close, we don't really know for sure where we are on that story. I mean, some people do, but most of us don't. I was with a friend Friday who's had ovarian cancer for 13 years, and she's much more aware of things than perhaps I would be, but I could die tomorrow, So we don't really know where we are. So it's thinking about what it would mean to live a good and decent life when we can't do everything that we can do. And I think thinking of our lives as a story and what's a satisfactory ending to it, I think helps me and might help us all. But socially, on a larger scale, I don't know.
Let's use that segue to take questions from the audience. Where's Running Jack? There he is.
Jack, here he is.
Where? How about the gentleman in the orange here?
I loved your story about the intergenerational and the kidney.
Well, I just wanted to address the Eskimo ice floe issue, because it seems to me that the notion of superfluous people and non-productive. I think just thinking about the last election, for example, some of Mr. Romney's very candid remarks about people who were superfluous, maybe 50% of the population. And I think it's a rather dangerous notion to start making judgments about that, whether it's in the political context or in the medical context. Once you do that, I think you're headed down a fairly slippery slope. Addressing the issue of what a good life is, it also seems to me that that's an issue that's applicable at every age. It's not just old age, and probably as a society, we don't kind of ask that question enough, when we're teenagers, when we're middle-aged, or when we're old age. I don't really necessarily see that as kind of an older age issue, but that may just be me.
Thank you. I'm not sure there's a question there, but I don't know if you wanted to some comments. Yeah.
I did want to ask about. Is this on? Okay. I did want to ask about. The idea that younger people and older people do not have a connection, that they don't
Do not
want,
have what?
do not have a connection, that there's no way that they could, or not anyway, but that young people don't want to be around old people.
This came up in an earlier panel.
Yeah,
Yeah.
yeah.
Okay.
And I'm actually in a situation right now and having an experience where I'm finding that to be absolutely not true. So one of the ways I want to suggest that we could start with this social relationship would be for young people and old people to have a sort of more formal relationship in their families, within their communities. I think we are asking young people to volunteer a lot, and there's opportunities for younger people to know older people in that context. I'm actually right now in a master's program and I'm by 20 years older than everybody in the program, and I'm fully accepted and I'm actually really enjoying it. So I think there is hope there. That's all I want to say.
Yeah, and I want to encourage you guys to respond to this too. This speaks to some of my broader questions about social institutions catching up with changes and how people are living their lives. And I also want to add another personal anecdote, which is I'm actually just about to move in when I have this baby with my mother-in-law, and I'm going to be in a multi-generational house where we're going to be doing childcare and things like that. And I actually was pulling up statistics on that, and that's a more and more frequent thing.
Mm-hmm.
But I didn't know if you guys had some comments on that as well.
Do you want to comment?
Well, I'm sorry, sir, I did not hear your comments very well. Sign of aging. But I do want to point out that when I say this, that we looked at this sort of third age as, and then I'll get to your comment in a minute, as sort of a void. You know, it used to be called a liminal period. You know, we exit from retirement and we don't enter anything. You know, it's just kind of this void. And for most of the other points in our life, if you're the kind of people that I suspect many of us are, we're always asking the question, how do I live a good life? You know, it's not something that's postponed to old age. I mean, it's been a question as long as I am thinking about things. But for much of our life, there are societal norms that tell us how we're supposed to live. You know, it tells us what, you know, when we're, 7 years old, we're in school, and, we go to college, and then we marry, and we have children, and we raise our kids, and we have jobs. You know, there are many norms that are conventional, accepted whether we like them or not. And the void comes, there are not the conventional norms that tell us what we need to be when we get older. And there's all kinds of people, often not older people themselves, but other people, younger people, telling us how to fill in that space to give it a sense of meaning or a sense of purpose, which is something we all need at whatever age we happen to be. It's just the question becomes more profound when we get older, partly because we are often marginalized in all kinds of ways. We can have invisibility stories, but it is a question that should mark our entire life, not just postponed. And in terms of young and old, again, sure, when people get to know you, and I mean, I have friends colleagues who are my friends who are the same age as my daughter, and they don't seem to think about me as the old lady. Maybe they do and they just don't tell me, but I mean, students have some sort of said, oh, she's such a sweet old lady, and I want to say old, maybe sweet, I'm not so sure, but but I do think informal, bringing people together, and formally, and I think that we've made an effort to do. I mean, all these online courses and classes, maybe that will begin to create change. Maybe not, but it'll create change in your life. It'll create change in their life, maybe not universally.
Well, I think we'll just take some more questions.
Yeah. Well, actually, we're going to take one more, and then we're going to go directly into, or we'll have to a little time. We'll take one more, and then we're gonna go on. But there's going to be lots of time for questions after Arthur Kaplan takes. So please hold on to them. Let's go with this gentleman here.
Yeah, is this on?
Yeah.
Okay. Yeah, I've noticed that's what's always seems to be missing from these discussions is the
Hold it a little closer.
yeah, talking about life extension, the science of manipulating a lifespan so you would extend maximum lifespan. This would not only increase the youthful aspects of life, but shorten the decrepit end of life. And why is that never discussed?
Is that never discussed?
I'll comment. No, it's not never discussed.
Right.
There's a lot of research on, manipulating the genetics of that. I mean, there's a very, active group of biological scientists who are working on that in one way or another. In some ways, the revolution in stem cells is the beginning of this. In other words, the ability to create body parts, which of course isn't really with us yet, although it is with some skin and some cardiac muscle, I think. This is sort of the beginning of this, but I think on the genetic level, there is research going on in this. It isn't really any of the topics that have come up with us today, but no, there's a big body of research on that. But just, to a little bit to, follow up on the previous topics, regarding your comment, the issue of superfluousness and some of what Diane Meyer raised earlier, I want to just echo, which is that the way we do medicine reflects, and maybe this relates to your comment as well, the way we do medicine reflects the kind of society we have. So if we're, gearing our system, as Diane Meyer said, to, the profit motive and giving everybody who's participating in the system the money, if physicians are paid by procedure, if the insurance companies are what gets all the middle of the money, and the pharma and device companies are reaping the benefits of their research, if that's the way medicine is going to prolong life, and including, some of these biological, biomedical research initiatives, if that's the way we're going, then that's, a political, economic decision about how we want to do medicine and what is the way to live. What is the way to live as a society? It becomes the social denominator of how we've decided to live, unless there are some kinds of interventions that Martha's talking about and that Diane was alluding to that we need. And the whole issue of postponement and postponing death, I think there's such huge variation in how people respond to this. It's hard to come down to a denominator of what to do.
That's a great segue to our next session. But first of all, I want to thank the two of you and to thank Sam. In our next segment, we're going to do the nuclear option in that regard, which of how we could change things. Arthur Kaplan is going to suggest that we basically stop all medical research, that medical research itself is the problem. He's going to make a modest proposal, and I suggest that we have a stand-up, sit-down for 2 minutes, and then we're going to come back, and Arthur Kaplan is going to lay a crazy proposal on you, and we'll see what happens.